Hi everyone, I'm Kathy, one of the medicine residents. This is one of my mentors, Dr. Moeller, a genius epileptologist. Today we want to talk to you guys a little bit about inpatient seizures. So let's get started. So this is how we're going to go through things, starting with a bedside assessment, a diagnosis, treatment, assessment, and then ending with some take-home points. So you are on call and you receive a call from a nurse saying, I think the patient is having a seizure. And what do? So first, ask them to describe what they see. Is the patient shaking? What was the patient doing beforehand? What kind of things marked their concern? Then, of course, very important is to check vitals. Is the patient hypertensive? Is the patient desatting? All these things are going to be important to help you find out whether or not this is seizure. Also very important, a super quick thing that can really change is finger stick. I've been called to stroke codes in the past where the finger stick was 19, and there you have your diagnosis that would make anyone seize, including me or you. Next, it's really important to get labs immediately, as soon as they can, because sometimes it's hard to document what you saw if there isn't a camera there. And if you show a big anion gap metabolic acidosis in these labs with a lactate of 6 immediately after, that kind of is documentation for everyone else to believe that there was actually something that happened. Besides, you and the nurse just saying, no, seriously, guys, they were shaking. Next, very important, and this is something a lot of people, I think, don't give themselves enough credit for, but you can always do an exam. You can try and interact with the patient. If they don't have a mental status, a lot of people say, how am I supposed to do an exam? And the secret is to be mean and apply noxious stimuli. Is there focality in the exam? Are they weaker on one side or the other? These things are going to help you really determine where the patient can go. Speaking of which, let's talk about that. So if a patient is doing great, they stop right away by themselves, don't eat anything, they are a little confused, but then they start to get better, probably okay for this patient to stay on the floor. And let's talk about the other worst case scenario. If this patient is totally out of it, they can't breathe, you call anesthesia, you intubate them, well, this patient's going to have to go to the ICU. And then step down is kind of this intermediate gray zone. If the nurses aren't comfortable with it, you're not going to be able to take good care of the patient on the floor. The ICU won't accept them because there are no ICU needs. So that's where step down comes in as a good intermediate. Now, what is seizure? What are things that cause seizure? It's basically your brain causing too much electrical activity. This is a brain, in case you guys can't tell. Here you go. Here's your little temporal lobe, frontal, parietal, and occipital. Here's your little brain stem. There we go. All right. So first, not all that shakes is seizure. And here's a great example of syncope. Let's take a break to watch this video.
Let me show you some people syncopizing. So these are German medical students. They're in the 80s, as you can tell by the outfit. It's really easy to make yourself syncopize. Don't do it now. If you bend down on your knees and hyperventilate for a minute or so, and then quickly stand up and valsalva as you stand, you will syncopize. So here's a healthy, normal German medical student syncopizing away. There he goes. He's taking a little longer than usual. There he goes. I want you to watch on each of these patients what their movements are like. So he's shaking. That's the myoclonus that reliably accompanies somebody who has transient ischemia to their cerebral cortex, or it may be the basal ganglia, we're not really sure. So she twitches a little bit. Those are fine examples. But you say, I can tell the difference. Well, you tell me if you can tell the difference between this guy. Watch this. Watch these movements. If you're seeing this yourself in the emergency department, I would argue this would be difficult to distinguish from a generalized tonic-clonic seizure, let alone if we're asking these patients' family members who are freaked out. Watch her. She's my I mean, this is a normal person. This is you. You can do this too tonight in your hotel room, wherever you want to do. But please stop asking people if they are shaking to try to discriminate seizure from syncope. It is not helpful. They are shaking, and there's just no way to tell the difference on that one basis.
Next, you can have strange complex migraines that have a focal thing. You know, you have a face and you're smiling, and then this side of their mouth is just droopy, and you know, their forehead is sprinkled, and you know, it just is a very focal thing. There's also this strange thing called limb shaking TIA that is kind of a strange thing that sometimes people see. Also, narcolepsy, sleep disorders, people can have weird shaking movements with this, and that can look a lot like seizure. Movement disorders where people have tremor that's very rhythmic and jerking and, you know, can look very much like a seizure. And of course, we have the always troubling non-epileptic spells. These are where people have seizure-like movements, but they aren't actually based off of abnormal brain and, you know, can look very much like seizure and, you know, really be a confusing thing. Now, if you do have a definite seizure, what can that be caused from? So in inpatient seizure, you kind of have a different population than that which you learned in med school about, you know, complex focal and absence and all those different things. In the elderly, the most common cause of new onset seizure is actually stroke. And if you see a patient who has AFib, their anticoagulation is held for surgery, you know, they have a sudden change in their focal that makes you think about stroke. Otherwise, you can have underlying mass like a tumor, abscess, vascular malformation. You can have an encephalitis that's autoimmune. You can have TBI. This can happen anytime after the injury. And of course, the thing that we see very frequently on medicine services, alcohol withdrawal. Some other things that you can think of, especially if patients are kind of in a different population than we usually see. For example, a febrile seizure in an infant or a hypertensive pregnant woman. You got to think about eclampsia and, you know, but in the meantime, you know, a lot of times it's just these usual toxic metabolic things. And of course, if someone is not getting their anti-epileptics, do not hold someone's anti-epileptics if they're having surgery. All right, so what do we do? Here is treatment. And what does this all mean? This is the official evidence-based guideline for the treatment of convulsive status epilepticus in children and adults, published by the Committee of American Epilepsy Society. What does this mean? Yeah, it's actually really, really busy. So let's just break it down into something that's a little more palatable. So, 1. ABCs. Stabilize the patient. Can they breathe? Are they turning blue? That's not good. Sometimes you need to intubate them to get control. You'll see this in the ED a lot. Someone comes in shaking, seizing. You can't break their seizure. You just gotta intubate them. Next, Ativan. So the new guidelines actually say to give 4 milligrams of Ativan to break the seizure. This actually shows that it terminates seizures more than, 2 milligrams, which is, what most of us probably have been taught. But, use your judgment. If it's a little old 90-year-old lady, you're not going to give 4 milligrams of Ativan. Next, you want to load them with something. This kind of breaks the seizure abruptly, but you need something that lasts a little bit longer. My favorite go-to is Keppra, one of the newer anti-epileptics with really much fewer side effects than a lot of the older ones. It's really great for, pretty much everyone, especially our patient population happens to be on a lot of medications. Keppra is something with very limited interactions. Then once you have that, you really want to go and get imaging. What is the underlying cause? If there's someone who, was on Coumadin with an INR of 8 and they had a fall, you're really going to just want to start with a CT. MRI is also, of course, very helpful if you don't think there's anything acute going on or if your CT is normal, but unfortunately, very inconveniently, it doesn't tolerate EEG leads. So that leads kind of us to the next thing. EEG, very, very helpful. Even epileptologists can't always differentiate what's a seizure and what's not, and EEG is really going to be key in helping you kind of solve. So, what is EEG? We learn a lot about EKG, but there's a lot we don't really get exposed to with EEG, and it's a similar idea. It's basically using little electrodes to measure electrical activity inside the body. So here is how someone might look with their EEG leads. This is their nose, their ear, their other ear, and you're looking down, and basically you take the signal from two different leads and convert that into an electrical signal that goes one way or the other, depending on where the signal is coming from. And if you have a whole bunch of signal that clusters kind of in one area, and you look at all the different leads put together, you will see something that looks like this. So you can see how, these are corresponding to different leads, like this would be this, and you can see different patterns with them. So here's an example. You walk in and you see the patient's EEG and it looks like this. What the heck are these things? Is this a seizure? Is it something worrisome? Actually, these are eye blinks. And basically, this is because the eye is charged. So when you close your eye and your eyeball rolls up a little bit, it causes a signal to be seen on EEG. So this is okay. What if you walk into the room and you see something like this? Goodness gracious, this is bad. This is a seizure. So, what's going to be really helpful for the text. So something that can be helpful is if you see the patient doing something concerning, you can mark the EEG, and then when the fellow is looking through hours and hours and hours of these squiggly lines, they might have something that they can focus their attention on. If you see the patient doing something strange, you can type in right into the computer what you're worried about, or if you're doing an exam, that's also something that you can mark on the EEG, and it'll be helpful for whoever is reading it later. Literally, you are just scrolling through pages and pages and pages and pages and pages and pages and pages of stuff. So it's really, really helpful if you mark something and then you can kind of see what it looks like and jump to it directly. Do it and feel empowered to help comment. Here's just another example of something that might look scary. EEG is a huge, huge, complicated topic, and it's a really difficult fellowship to read, but you can see things that look scary like this, but it actually just turns out to be chewing, because you are creating muscle artifact. These are your cheek muscles clenching. So let's break down what the EEG report means. Sometimes it can be very, very confusing. You see this big, long, complicated amount of text with all these strange words like alpha rhythm, delta rhythm, different frequencies. What does this mean? Well, I think it's easy to just break down the important things that you can see. So if the report says this person is having seizures, that is concerning. Something else that reports frequently say is LRDA, which is lateralized rhythmic delta activity. This is the brain having some amount of overactivity, and it's thinking about seizing but not quite doing it, but definitely is something that's concerning. If the report says there are no epileptogenic periodic discharges, that's reassuring. No seizures is reassuring as well. A lot of the times when we get EEGs in medicine, we kind of have patients who are just a little bit off, and frequently the EEG will kind of be nonspecific, and they'll say it looks like some kind of metabolic encephalopathy or some generalized slowing. This means there's no real point that's causing a lot of excitement in the brain and causing it to have concerning things. It's more that the brain itself is just kind of tired. All right, so let's try to put this all together in our assessment and plan. Once you have some data, you can just kind of describe what you see and get some story from the witnesses, because sometimes the patient can't tell you exactly what happened. Then once you have this, it's really helpful to go back and talk to see if there are any risk factors for, things that would predispose the patient to seize. For example, is there family history? Do they have childhood seizures, brain trauma? Sometimes if the patient's younger, helpful to get a history of how the pregnancy went. And, if they have a bunch of metabolic derangements, if they have liver failure, all these different things that can be concerning. And then, of course, as mentioned, the exam is very important, and if there is focality to the exam. Lab data, again, like I mentioned, to support, people often throw around the idea of getting a prolactin, which actually, hasn't been too helpful in my experience, but is something fun. And, if it's absolutely abnormal and then quickly normal afterwards, it's something that might help you sooner or later. But I find, like I said, lactate and anion get metabolic acidosis being most helpful. And of course, EEG. What does the EEG data say? That's going to be super helpful. Imaging, MRI with and without contrast is going to be really helpful, and showing you if there's any underlying abnormality, or just a head CT if there's a small bleed or something like that that's irritating the brain. And then what your differential is. 1, is this even a seizure in the first place? And 2, if it is, what do you think the cause of this could be? And then what further workup would you do? You can always do video EEG monitoring, which is going to be really helpful. Basically, you have a camera on the patient, and then you are also recording the EEG as well. And this just helps you kind of get a sense of what's going on in their brain and what they're doing at the same time. This is someone's head with EEG leads. So, and then whether or not they need treatment in the acute setting. Like we said, you can give Ativan, you can give Keppra, but do they need something really long term? Is this something that just happened once because someone has really bad meningitis? That's kind of a discussion. All right, so finally wrapping up, let's talk about some take-home points that we have. So basically, seizure. This is a very, very brief dip into the ocean of seizure, but mainly important things I want to emphasize are vitals, labs, and EEG. We have a differential of things that, could cause it and things that can mimic seizure. We have the status protocol for things that you can do in the acute setting, but let's be honest, you're probably going to ask for help from the neuroconsult team at this standpoint. I think it's also important to touch on things that we didn't really get to speak about earlier, but really, who needs long-term therapy? You can refer them. We actually have a first seizure clinic that you can refer people to for people who might not need long-term therapy, and they can follow up there and kind of discuss if they're able to come off AEDs, if you're worried about them, if they need to continue it. Also, it's very important to counsel your patients about driving and swimming alone if you're worried about, them having recurrent seizures. So these are just kind of some other thoughts that, you can read about more and learn about. So thank you for watching this video. I hope it was helpful, and just wanted to point you guys to some websites and resources that might be helpful. Of course, we have the great evidence-based guideline and review of seizure medications, and then we also have some of the information on hospital onset seizure, which I think is how we encounter seizures, and of course Up to Date has everything. It is Word. So thank you all for watching, and thank you so much to Dr. Moeller for helping me put this together, and good luck. Bye.